The recording has started.
All right, thank you. So welcome everyone to the Rule Advisory Committee for Senate Bill 822, Network Adequacy. My name is Brooke Hall, and I am the policy analyst in charge of this rulemaking. In the interest of time, we're not going to do introductions today. But before we get started, just some quick reminders on meeting etiquette. Please stay on mute unless you are speaking. Use the raise hand feature if you'd like to comment or ask a question. And when you are speaking, please introduce yourself so we can capture clearly for the record who is speaking. So the agenda for today, a review of comments received. We'll have a conversation about quantitative reporting and implementation of quantitative reporting. We'll review the draft rule. We'll review a statement of need and fiscal impact. Have some time for public comment, and then next steps. And then in the materials before today's meeting, you should have received the comments that the division received since the last RAC, the draft rules, and then a blank statement of need and fiscal impact. Any questions or comments before we get started? Okay. So a review of comments received. We did receive 3 comment letters, I believe. In the interest of time today, we're not going to go through them, have the RAC members who sent them to us go through them, but we did send them out to the RAC members. So please, if you are interested in those comments, please feel free to review them. But again, we have a very packed agenda today, and I want to make sure that we get through everything. So I'm not going to have RAC members kind of give an overview of their comments today like we usually do. But again, they were sent out, and I'm happy to send them out again if anybody needs them. So please feel free to review those at your own discretion. So next would be a quantitative reporting implementation discussion, and I'm going to hand that over to Cassie.
Hi, everyone. Good morning. My name is Cassie Susi. I am the compliance manager for the division. I've been working closely with Brooke as well as other folks internally, including members of my team, so compliance analysts, as well as our business analytics team and other members to kind of work through what our quantitative reporting looks like for network adequacy. What we want to propose, since this is pretty complicated, and I know that there have been quite a few discussions during our RAC about what insurers need to provide that data and information, as well as just trying to figure out what is going to work best for us to review compliance with the statutory requirements. What we would like to propose and get feedback on is delaying the quantitative reporting for this year until next year and pulling together a smaller group comprised of insurance carriers as well as providers and other members of the RAC to weigh in on really kind of working on what the quantitative reporting form looks like and providing feedback to us of what will work best with the systems and data that you have to work with for what we're going to be requesting. So this would be, we would put this forward to be a requirement for reporting next year. So this would be a project kind of separate work group from the RAC to work on just kind of the quantitative reporting aspect. I'll pause there and see if there are any reactions, questions from the Rulemaking Advisory Committee on that proposal. Antoinette.
Yeah, hi, good morning, Cassie. This is Antoinette from Cambia Health Solutions. We support that 100% with respect to your proposal. Again, as we also communicated in our comment letter, it will really provide as adequate time to collect substantive data and for the DFR to have that data to review. We'll
Mhm.
also be interested in being part of that separate work group outside the RAC if you will be utilizing health insurers as a resource as well.
Great.
Thank
Thanks,
you.
Antoinette. Seth?
Yeah, I just wanted to clarify then, would it be looking at January 1st, 27 that the reporting collection would begin? Just wanted to clarify like the date timeline for that.
I believe so. Brooke, remind me about the timing on this reporting.
Reports are due March 1st, March 1st, I believe. So it would be March 1st, 2027 that reports would be due. It's in March, so it's either March 1st or March 31st, 2027.
Thanks.
And a comment with that, we would still move forward with having some reporting for this year. It would look like pretty similar to what we've done previously. So next year would be like the more expansive, more in-depth reporting, but we would still require some reporting to happen for this year. So there would still be reporting that happens this year. We just want to take our time to get it right or get it as right as possible that we can.
So the qualitative will still be due, just not the quantitative
Yes,
portion.
correct.
Okay. Thank
Yep.
you.
Bo?
Yeah, I just want to kind of repeat what Antoinette mentioned earlier. PHP were supportive of that delay and to further work on the details, and we'd be interested in participating outside the RAC. But also I had a question with that delay, I believe that'd be March 31st, 2027 for the first new report. Would that report include plan year, I guess this plan year, current plan year, or just the plan year previously?
That is a very good question, Bo, and I think it'll be something we should talk about both internally within the division and then also as the working group. Yeah, great question. Don't have an answer right now.
Okay, thank you.
Merlene.
Hi, from Kaiser Permanente's perspective, we agree with Cambia and Providence and about the supporting the delay, getting the reporting criteria clearly identified so that we're all doing it in the expected way. And Kaiser Permanente would also be interested in participating in that separate work group to look at the reporting.
Great. Thanks, Merlene. Melissa.
Hi, I'm Melissa Todd, and I'm here on behalf of OIMHP, the Oregon Independent Mental Health Professionals. And I just want to say that we will defer to DCBS's judgment on whether you feel like it would be beneficial to work on the reporting requirements for a longer time. And we trust that because we've seen that there can be problems when the reporting requirements are not clarified for all involved. And we just ask that the work group it include a representation of providers and as well as insurers.
Yeah, thanks, Melissa. And yeah, we want to have an inclusive work group to work on this and make sure that it won't be, like a full rulemaking advisory committee, but it'll be a working group to make sure that we get multiple perspectives on what we'll be requiring. So thank you.
Thank you. We appreciate that.
Yeah. Gary.
Yeah, Gary Hollis, City Source Health Plans. Again, we support the delay. What I was trying to understand, Cassie, is do we have to put something in the rule that says the reporting the quantitative reporting won't start till 2027? Or is that something, or how's the division going to provide guidance in that?
I think what we'll do, and we'll check this with our council as well, but we will make sure to make it clear within our guidance for rule or for the reporting that we will be doing the qualitative reporting for this year, and then have kind of both the qualitative and the quantitative for 2027. We'll check with our council to make sure we don't need to put anything in rule. But we'll make sure to have that documented publicly on like our website for the reporting. So it's not a secret to anyone. Anyone can go look it up, but we'll clarify if we need to put that in the rule or not.
Okay, and again, Pacific Source is more than willing to jump on that work group if you need members to review it. Thank you.
Great. Thanks, Gary. Okay. So just to recap really quick, what we'll plan to do for the reporting for next year, 2026 in March, there will be qualitative reporting that will be required. It will look similar to previous years of reporting. There might be a couple extra questions to align with the statutory requirements, but it'll look very similar to what you've seen before. We will get you drafts we'll get some drafts out to the whole RAC to look at in the next couple of weeks. The goal is to have that out to you all before Thanksgiving, so you can take a look at that and provide feedback. Again, it shouldn't look too terribly different from what we've done previously. So that will be for this year. We will look to getting a working group together, probably, what did we say, Brooke? January?
Yeah, I think we said after legislative days in January, because isn't legislative days in January?
Yeah, so we'll start
in
that in January, so we can get through the holidays. We'll work internally and reach out to individuals of the RAC to see if you are available to participate, likely on a monthly basis, to review the kind of quantitative reporting and deep dive into questions about that. And then in March of 27, we will have the quantitative reporting finalized along with the qualitative to have a full reporting. And Bo will get back to you about the question of whether it would be inclusive of this year or just inclusive of it would be 2026 at that point of the plan year. But yeah, Antoinette.
Yeah, so with that, and I'm sorry if I missed this in the communication, because as you know, we have just multiple rulemakings going on simultaneously. So with that, are we looking to making this a temporary rule, or are we still moving forward with making it along the lines of a permanent rule?
So Antoinette, you're jumping ahead in my agenda here, but that's fine.
Oh.
It's totally okay.
Sorry.
It's
I'll
okay.
wait, I'll wait.
I was planning on having this conversation later in the RAC, but we can have it now. That's totally fine. So we did have a conversation, I think at a previous RAC, about the division filing a temporary rule in this rulemaking. However, there has been some concerns brought up around whether or not a temporary rule is appropriate in this case, because there are, some requirements regarding filing a temporary rule. And some of those are that in order to file a temporary rule, the division has to demonstrate that a failure to act promptly will result in serious prejudice to the public interest or the interest of the parties concerned, and that the rule is necessary to address that harm. So I kind of wanted to have a conversation with the RAC around whether in this specific case, the RAC felt that there was harm in this case. I think if we don't file a temporary rule in this case, that means that we will just proceed with a permanent rulemaking, and we won't have rules in place in this case by January 1st, 2026, and we likely we'll have rules in place sometime in 2026, but I don't know when that will be. So I'm just interested to hear how the RAC feels, which approach would be the best, and whether the RAC feels there would be harm in this case. Marlene.
I am not seeing that I feel that there would be harm if it wasn't adopted by January 1st, especially given the way you're separating out the work stream for the reporting. If the reporting was supposed to be under the brand new format and was due by March 31st, there would be harm. Well, I'm not sure if it'd be harm, but it would be very hard to get the work done if the rule wasn't finalized and we were expected to report that way. If you are doing the separate track where the reporting that we're going to do in 2026 is going to look similar to what we've done in the past, I could see the permanent rule just happening in 26 wouldn't cause harm. I would want to make sure, though, that we're not waiting until the end of 2026 to get it done, because we're still going to need, once you have like the new criteria of what you're reporting, you're going to need to have time to build it in, collect the data, and make sure that everything is in place so that you can do that reporting.
Yeah, I appreciate that, Marlene. And that's a good point. And it begs the question about how far the RAC thinks we are away from a permanent rule. My thought was that if we moved forward with a permanent rulemaking process, that we likely, hopefully, wouldn't need more than a couple more RAC meetings to finalize the rule. The majority of the work seems to be focused on the reporting template, and I had really hoped that we would have a permanent rule kind of in place by, regardless of whether we went the temporary route or the permanent route, by March of 2026. So that was kind of my internal deadline for myself, was March of 2026. Melissa, go ahead.
So I think I have more of a question right now. Is just what are the implications of not having a temporary or permanent rule filed by January and waiting until March? Do you have an idea of why what the difference would be between if we filed a temporary first and then a permanent versus just waiting and not filing anything until March?
If we don't file a temporary rule in this case, it means that we proceed under the current rule set. So the current rule set remains in place as is, and we proceed under that rule set. If we file the temporary rule, then it repeals the rules that are repealed under this rule set and replaces them with the current rule set. So it does the repealing and the replacing and the amending that is under the current rule set. But it doesn't mean that there would not be rules in place. It would just be the rules that are currently in place.
Mm-hmm. And would that cause some sort of a hardship for anybody involved, whether it be DCBS or insurers or the public, to have to continue to operate under the current rules until March?
That's kind of the question that we're trying to answer. As Marlene pointed out, the reporting that the division is planning on proceeding under in 2026 is mostly aligned with the current rules. There might be some minor differences and additions, but it is mostly qualitative reporting that is aligned with the current rules, because the quantitative reporting, the additions under the current rule set require some more thought and some more process kind of oriented time for insurers. And so I don't, that's the question that I'm trying to answer with the RAC, of whether there would be harm in proceeding under the current rule set. It sounds like maybe there wouldn't be, but I'm curious with what others' opinions on that would be.
Okay, yeah, thank you.
Mm-hmm. Antoinette.
Yeah, we don't see any, Cambria doesn't see any harm in keeping what is current, what we're currently doing now, which is no report on the quantitative. But given that, the DFR is proposing to delay the first reporting until March 31st of 2027, I guess my concern is if we move forward with adopting it as permanent, and with the work group that will be convened in 2027 to have further discussions on some of the specificities surrounding the reporting, we would, if there are any changes that impacts what's been permanently adopted, the DFR would have to reopen it again. And then with doing it more for temporary, it means that it also aligns with the underlying statute, which was that it'd be effective January 1st, 2026. But temporary means that there's still some details to be ironed out, but this is what you should follow in the meantime. To me, again, may make sense to go that way too, to align with the fact that, yes, the rules, we had something in place, effective 1/1/2026, but however, the DFR has made that decision, with RAC member approval to delay the first reporting until 2027. So that's how I am kind of looking at it as well. But there's no harm in the delay. It's just a matter of, do we proceed temporary or permanent, given some of these nuances with each. So that's my comment on your proposal.
Yeah. And I appreciate that, Antoinette. I will point out that temporary rules can only remain in place for 180 days, and then we have to file a permanent rule. So, if we weren't able to kind of iron out the reporting template in that time, we would still have to file a permanent rule before that 180 days kind of passed, whether the reporting template was finalized or not. And you're right, if there were changes to the reporting template that necessitated changes to the rule, then we would need to reopen the rule to make changes to the rule. But my hope would be that the rule would kind of outline what the requirements are, and then the reporting guidelines would kind of outline what the reporting guidelines are, so that we wouldn't have to, put every element that is required for reporting in the rule, so
Absolutely.
that, when, data elements change, or when there are different needs of the division, or different needs of carriers, we don't have to open up the rules every single time, because
Right.
that becomes problematic.
Right. And with 180 days for the temporary rules, I mean, it gives us a time frame, the clock is ticking to just get this done too. So, okay. Thank you. Thanks for that explanation.
Seth.
Seth Johnstone, Basic Rates Oregon. Just wanted to clarify, the House Bill 2002 RAC sort of defaulted to this RAC to define unreasonable delay and wait times. Just was, from a harm perspective, curious if that would still be defined at a certain point through this process, or if that would be delayed through this as well, that we would have that definition defined so patients could go out of network if they truly don't have adequate wait time to meet their needs.
Yeah, well, I believe my understanding is that unreasonable delay is defined by the quantitative standards that were implemented in rules. So an unreasonable delay would be anything that is outside of those quantitative standards. So the associated appointment wait time standards or time and distance standards. But I don't believe that we were going to put a definition of unreasonable delay into rule. Part of the reason for that, Seth, is because there is no associated definition of unreasonable delay in federal statute or any state statutes. And I don't necessarily want to make up a definition of unreasonable delay when there is no, associated definition kind of in other kind of statutes that also, have that those rules are associated with. And so my thought was that the unreasonable delay would be defined by the associated quantitative standards. I hope that makes sense.
Yes, and I was curious if those would be like through this process delayed in terms of what need to be followed, or if those would go into effect by the 1st of 26.
So the reporting on the quantitative standards would be delayed until 2027. But Gary?
Thanks, Brooke. Just to comment on this in regards from Pacific Source is, we would like to see if the rules don't get touched, no temporary, no permanent, let the rules go. I don't see any harm. These rules are focused on individual small group right now. The legislation brought in large group. Those individual small group need that greater level of, say, consumer protection. And these reports are purely for analysis purposes. So I don't see the harm here if we delay any type of rulemaking until next year, as opposed to trying to cram it through now, because I think you made with some questions. Just our concerns here, listening how we're going about this, I just don't see the harm if we don't touch the rules at all, let the individual small group go through. And then next year we take on incorporating large group and the quantitative information.
So I'm sorry, are you saying that we should file temporary rules, but just as it relates to individual and small group?
No, I wouldn't touch the rules at all.
Oh, okay.
And let them go as they are. And then next year we work through all these details and things like that. Because I think you're going to muddy it up with temporary rules or trying to push through permanent.
Yeah. Okay. I see what you're saying.
Yeah.
Thank you, Gary.
Thank you.
Any other thoughts? Melissa?
Just another question for clarification. So I'm just thinking through what is in SB 822. And so what would happen if we delay the rules and to March, which isn't, if that's what we're shooting for, that's a few months, but essentially network adequacy would not apply to large group plans until the rule was filed in March. Is that
Jesse, you're gonna have to help me out with this because technically the statute is in place and plans are they have to adhere to this. It's a law, so they have to adhere to the statute, correct? So, but the rules, so it's confusing.
Yeah.
It is very confusing.
Can you repeat the exact question? I can try to help.
So SB 822, one of the things that the law did was extend network adequacy requirements to large groups and employer groups, and so if we delay finalizing the rules till March instead of getting something temporary for January, does that delay the application of network adequacy law until March for those large group plans?
Yeah, that's a really good question. And as Brooke was suggesting, it does, I think, create a little bit of a confusing situation because the law would still apply. There would still be an expectation that a large group was providing an adequate network according to the standards outlined in the law. But, the law is kind of premised on the idea that there would be rules specifying quantitative standards and so forth. So there would be a period during which the requirement was somewhat vague, I think, but it wouldn't delay the applicability of the law. It would just delay kind of filling in all of those quantitative details.
Right. Okay. And so I'm just thinking out loud. I have no idea what you guys can and can't do, but is there a possibility of putting into writing some sort of guidance as far as just to advise on what you just said there, that it is in effect, the statute is in effect, even if the rulemaking is still continuing on? I'm just thinking about the harm piece, and that may not mean that there is harm, because I'm assuming insurers are already making preparations, but that's the one thing that I'm just wondering about.
I think that's something we could take back and discuss, whether would be worth issuing some kind of interim guidance in the form of a bulletin or something like that.
Yeah, thank you for the clarifications.
Thank you, Jesse. And Gary.
Hey, just here, what I want to clarify is, the rules, the way they sit today, it hits the individual small group. It's just that large group that is being brought in. And like I said, I don't see the harm there because large groups generally have their own benefit consultants. They have their own experts that evaluate networks. So that's why I say delaying it a year, I don't think is harm. Let things go. Let the carriers continue to do the individual small group network adequacy report we do, minus the quantitative, and then we can take. So again, I know that the attorneys get into this and all that, but if you take a step back, what is it really that bill did? They want more reporting is what they're doing. And they want to bring in large groups. It's like, okay, does it hurt? Is there harm if we wait a year? That's why I'm just asking.
I appreciate that, Gary. Any other thoughts? All right, so I think we'll take all of this feedback back and have an internal conversation about it, and then we'll determine the best route forward, whether that's kind of a temporary rule or moving forward with a permanent rule. Regardless, we're going to have to continue to have more RAC meetings because we do have to file a permanent rule in this case, and we're not there yet. But I don't anticipate having a RAC meeting in December. Likely we'll skip December and probably pick up RAC meetings back in January, unless anybody in the RAC has concerns about starting back up in January.
Would this be the working group, or this will actually be the RAC?
Yeah, there would be two separate work streams, Antoinette. There'd be the work group for the to kind of better define the quantitative data reporting template, and then there would be the RAC to outline the rules.
Okay, got it. Thank you.
And Karen, go ahead.
So knowing that short session is in February, I will not be or would not be scheduling a RAC meeting as just a general guideline.
In February?
Correct.
So one in January, but not
So one in
February.
January, and then I guess start back up in March.
Okay. right, any other thoughts before we move on? All right, so let's, I think the next part of the draft rule was, I'm sorry, of the agenda was reviewing the draft rule, is that correct?
Yes. Let me get the screen going again.
Okay, so here's the draft rule. Once again, I highlighted because obviously there's been a lot of changes and this is a very complicated rule set. So I highlighted all of the changes in the draft rule. The first change is to this purpose and statutory authority rule set. And originally in the last RAC, there was a statement in here saying that the requirements applied to the adequacy of networks serving enrollees who reside in Oregon. At the RAC and after the RAC, there were questions around, what about an individual who lived in Vancouver but worked in Oregon and had an Oregon health plan. After the last RAC, Cassie and I met with Washington State to see how they handle these kind of cross jurisdictional issues in their rule set, because they have very similar kind of cross state issues. And they have a very similar statement in their rule set saying that the requirements of their rule apply to health benefit plans offered or renewed in Washington. The underlying statute, SB 822, also says that it applies to health benefit plans in Oregon. And so we changed this to say that to match the underlying statute and to also kind of mirror the Washington statute to say that the requirements apply to health benefit plans offered or renewed in Oregon and to the provider networks used to deliver services to enrollees covered under those services, or sorry, under those plans. Thoughts? Scott.
Hi, good morning, Brooke. Scott White from Moda Health. So this verbiage is basically expanding Oregon network adequacy requirements potentially to like secondary or rental networks covering individuals outside the state of Oregon who are on large group plans. So let's say a member is in Texas, and there is not the Oregon network that we would file to you and have all the data. They're on a rented network or using Aetna or something like that, because we're a large group now with this. Are you saying that Oregon network requirements would apply in that scenario? We're just getting into things of extraterritoriality here that would be interesting. It just seems like this would be limited to Oregon networks.
Yeah, I mean, I think that the way that we were thinking about it is that part of the reason that CMS, put the percentage requirements around the quantitative standards was for situations like this. So, the quantitative standards require 90% of enrollees to meet the access standards. So in situations like you were describing, that would fall in the 10% that don't meet those access standards. But happy to hear, thoughts
I
about
guess
that.
reporting, Brooke. I mean, I understand that piece, but like reporting, I mean, how would we report so for example, if it's a network in Oregon, we're reporting that, right? We know that the Connexus network for Moda, we're going to be reporting that. But if let's say a large group has a member in Connecticut and they use an Aetna rented network to cover national, right, for large group. Would I report the Aetna network? That doesn't seem to be the intent, and that would be extremely messy, where you have responsible for reporting rental networks outside of the main network. That's just to me, this reads where that could be interpreted that way for moving forward for the DFR, and we all might agree, oh, that's not what it means in the rule, and as we discussed today, but someone down the line could say no. It's at the health benefit plan level, which means that you would have to submit information about networks covering large group members in different states.
Yeah, and I don't think that's the intent, Scott. The intent would be, to report on networks in Oregon covering Oregon. And so if this language, doesn't get us there,
Yeah.
then I'm happy to take suggestions about what does. But my
Okay.
concern is, I want to also capture those individuals who may live in neighboring states, but also work in Oregon and have Oregon health plans. Those individuals also should be subject to network adequacy requirements.
Yeah, it gets difficult with large group in the mix to differentiate between the neighboring states piece of
Yeah.
that and then all other states. That it just gets wild to try to parse that out if the true intent is Oregon-based networks.
Yeah, totally understand that. So perhaps we need to do some more thinking about this language, but I want to ensure that we're capturing kind of some of those individuals, because we do have a lot of individuals. We know that we have a lot of individuals who may be living in neighboring states, say, living in Washington or living in Idaho, but working in Oregon and receiving, coverage under Oregon health plans, and we want to make sure that they are subject to network adequacy requirements. Antoinette.
Yeah, I don't have much to add because Scott basically concerned about that. We will look at how we can improve that latter part of that sentence in terms of and to the provider networks used to deliver services to enrollees covered under those plans, because I think, yeah, it's just very broad and I think you did try to explain this, but it also means that we can use these providers, well, interpret it to mean that we can use these providers also to satisfy network adequacy. But I think we just need to rein that part in a little bit. So yeah, we'll look at what language we can provide. I did in my comment letter suggest language that I think may close the loop, but I'll go back to my SMEs to just make sure that that's still solid.
Thank you, Antoinette. Appreciate that.
Mm-hmm.
Merlene?
Hi, I wanted to offer the perspective that in the state of Washington, when we are doing network reporting, we are doing Washington plus the neighboring states of Idaho and Oregon, if Idaho and Oregon are used to provide the adequate network for enrollees. So I would want to make sure that the language is not so broad that we would have to be reporting to Scott's example, somebody living in Texas on it, because it really expands the type of reporting that we would be doing. We, of course, want to make sure that all of our enrollees have an adequate network to receive services. But when we're talking about what we're putting into the report and which providers we're including in that reporting, just look for it to be tightened up a little bit. And I'll also go back to my subject matter experts to see if they have better language. But thank you.
Yep, appreciate that, Merlene. Any other thoughts? All right, and you'll notice throughout I just added the correct Oregon law and chapter here. So Oregon Law 2025, Chapter 541. That's where SB 822 is currently housed. All right, Karen, you can go down. I think the next section is down very, very far in the network adequacy. Yeah, that's just the Oregon laws. So it's in the yeah, nationally recognized standards. Okay. So in this section, we added number 2 and number 3. This is based on a comment that was received after the last RAC. CMS does publish alternative time and distance standards for counties that are known to not be able, to adhere to the current time and distance standards. They do publish them for each specific year. And so for number 2, we're just making it clear that we are adopting the 2025 CMS time and distance standards as our benchmark time and distance standards, and we made those available on the division's website. And for number 3, we're just making it clear that carriers can use those alternative time and distance standards for specific provider types or counties in the specific year. Let's see. In any plan year. Let me start over. We're making it clear that carriers can use those alternative standards in their Oregon filings for that year, but only for provider types and geographic areas identified in the applicable CMS guidance. And I didn't list where that guidance is available because, again, that guidance is published yearly, and so it would be available on the CMS website on a yearly basis. So any questions about that? And we also will be making the alternative time and distance standards available as a reference in our quantitative reporting template. Scott, go ahead.
Hi, Scott White, Moda Health. Just this was in my comment letter, but just letting you know we continue to support the alignment with the federal standards. Just because they're meant to address commercial insurance and they're not relying on standards that are applicable to other programs such as Medicare and Medicaid. So appreciate this being in there and support it.
Marlene?
Hi, I just wanted to thank the DFR for adding the alternate standard language in there. It really clarifies for us that we're still allowed to use those. So thank you.
All right, moving on. And again, there's the applicable Oregon laws and chapters. Quantitative network. Oh, I'm sorry. Can you go up, Karen? I think we missed something. No, okay, go down, I'm sorry. Okay, quantitative network adequacy standards. In A, again, this is the travel time and distance standards, which are available in Appendix E of the CMS network adequacy template for plan year 2025, which we've adopted as our benchmark time and distance standards. We made these available on the department's website, and so I just inserted the link to where those are available here. Any questions about that? Okay, moving on. Okay, network adequacy reporting requirements. You'll notice that this kind of whole rule was rearranged just to make it a little bit clearer and easier to read. All the reporting requirements are now under subsection 2. Under subsection 1, I inserted provider network used in connection with, just to make it clear that the reporting is at the provider network level, which is something that we talked about previously, having it at the provider network level rather than the plan level. And then we added that when a single provider network is associated with multiple health plans, the carrier must report once for that network and include all health benefit plans and enrollees for that network. This is just to make it easier on us, to analyze the data that's being reported and to make it easier on carriers, for administrative purposes as well. So any questions about this? Gary.
Just one thing when we were brainstorming on this, if there's a network out there that has no active plans, do you still have to report on it?
If there's a network that has no active plans.
If somebody piloted a network, they had an idea that they want to put a product in a network out there and nobody bought into it, do you still have to report on it?
Cassie, do you have thoughts about that?
Yeah, I think there might be more. I think we would want to know, but I don't know if we would ask for the full reporting unless it's being utilized.
Okay, it was just something folks came up with. That's why I was going to ask you.
Yeah. I think I don't see like the intent of this is to really understand how the networks are impacting, right, access to care, essentially, right? Time and distance, we're talking about that kind of stuff. If there is no consumer utilizing that network, right? No large group employer chose it or for whatever reason, I don't see why we would need a full reporting. I think we would just want to know it exists in case it does become something that needs to be then reported on in the future. But those are just my initial thoughts right now.
Okay.
Yeah.
No problem. Just wondering if we have to modify it, for it to say that now we're going to include all health benefit plans and active enrollees, or at least one enrollee for that network, is what I was thinking.
Yeah.
Okay.
And Christina.
Hi, Christina Wu from Aetna. To piggyback off of Gary's comment, or in situations where, for example, we may be pivoting our network strategy and, not, no longer offering a particular network and transitioning those plan sponsors or members to other networks that the plan offers, right? For example, so I'm two things about that. First of all, it might be helpful to consider like a waiver type of situation where, you include in your filing, we're waiving submitting the network filing for these networks because there's no membership, right? But number two, to the extent that these are public, specifically around the waiver requests, it might be helpful to consider whether or not those could be held confidential, right? Especially if some of those waiver requests might be filed ahead of potential network withdrawals or updated plan network designs, because, obviously we would want to make sure that the industry or our competitors are not able to see, some of our network contracting or product strategies before regulator review, if that makes sense.
Yeah, that does make sense. I appreciate that, Christina. Any other thoughts about this change? Okay, moving down to 2D. This is the previous section which asked for some evidence of compliance with quantitative access standards. And I think the language here was previously a little bit confusing. This language also is, it had the language around appointment availability, which, was confusing and not many knew what that meant. And so I reworded this to try to make it a little bit clearer what we're asking for. And I made it so that it matches what is currently being asked for on the quantitative data reporting template. So these categories here, A through H, are all of the columns that are currently being asked for on the quantitative data reporting template. So it currently asks for each provider in the network, including but not limited to these specific categories, and then provider and facility name, specialty provider type, street address, county served, contact number, whether the provider is accepting new patients, whether it's located in a low income zip code or a health professional shortage area, and network affiliation and tier level, if applicable. Scott?
Hi, Brooke. Scott White, Moda Health. For the county served designation, is that meant to be the county the provider is located in, or is that for each provider we would have to list each county that they could potentially provide services to?
Yeah, it's meant to be the county that the provider is located in. So the current quantitative data reporting template, it has like a list of all the counties in Oregon, and then it says, whether it's in a, what are the county designations? So a large metro, micro county with extreme access considerations, and it asks you, so it's meant to match those specific categories. So that the county served is meant to kind of mirror that particular column where it's asking you to list the providers for that county.
Okay, so location of provider, basically.
Yes.
Okay, thank you.
Gary?
Gary, Pacific Service. So in regards to that, we do have providers that may serve multiple counties, and I think the template's going to accommodate that, correct? They may have satellite offices in the rural.
That's a good question. I don't know, and Mark, correct me if I'm wrong. I don't know if the template currently accommodates that. That's something that the work group may have to look at, but you're correct that the template likely should accommodate that. Yes.
Right. Okay. And then under sub D, we had a little confusion why we called out behavioral health, substance use disorder, and reproductive health when you're asking for all the providers. Is there something more there? Because that says, is there something specific or only those three, even though it says not limited to?
It's just because those are the specific categories that are called out in the statute.
Okay. Just a suggestion. I would take those out to cause less confusion. But again, if there's a purpose there, fine. But I think if you just say for each provider in the network, provide the following, it may help us. But again, just a suggestion, just clarification, making it simple.
Okay, appreciate that, Gary. Other thoughts? All right, moving down. Okay, so this is the cultural competency information, and this was reworded at the suggestion of one of the RAC members in a comment letter after the previous RAC. And it was suggested that we kind of reword this to better match the categories that are identified in SB 822 itself. And so that's what we did here. So we're asking for of network providers who self-report as offering interpreter services for one or more spoken or sign languages, number or percentage of network providers who self-report the ability to provide services in one or more languages other than English without the use of interpreters, and then the number or percentage of network providers that self-report specialized experience or clinical focus in serving one or more of the following populations, and then those populations match exactly with the populations that are identified in the statute itself. And then in B, any carrier initiatives, incentives, or programs designed to improve enrollee access to culturally and linguistically responsive care. Any thoughts here? Antoinette?
Yeah, internet for Cambia Health. So for the two little I's, number or percentage of network. Oh, okay, it needs to come down a little bit. Sorry. Number or percentage of network providers that self-report specialized experience or clinical focus in serving one or more. Okay. And then you list individuals with disabilities and individuals with physical or mental health conditions. Um, as you know, with the insurance, we send a survey or roster out to the providers to get this information. And we're going to get a lot of questions in terms of what do you mean by disabilities and also physical or mental health conditions? It's just, again, very broad. And given that we will be getting questions from providers, it may limit, what they self-report. We would like, you know, that, defined, or removed, because it's just, again, another broad field or category. So,
So you asking us to define what an individual with a disability is and what an individual with a physical or mental health condition is?
yeah, or just remove it.
Christina?
Hi, Christina Wu from Aetna. I agree with Antoinette's comments. Also, I think one other thing that you might want to consider is that disabilities or physical or mental health conditions. Those are like board certifications or specialized training, and so an individual self-reporting that information may or may not be consistent, for example, with their board certifications or any specialized, clinical rotations that they may or may not have done, right? And so I agree with taking these out because I don't know that like the plans want to be in the like the middleman between a member, for example, complaining and saying, oh, you said that whatever, specialize in individuals with this kind of disability, but you don't have, show me your, clinical background or practice or whatever. And I just think that it puts everybody in a really awkward situation. I think what you're trying to achieve here is that, if you are a person with a particular type of disability, it would be helpful to, for example, understand what providers are in the network that might be able to provide culturally competent care. I think that's what you're getting at. But I think reporting this information and collecting it from the providers, and then potentially that information being reported out in any certain way, could create confusion and inconsistencies in terms of roles and responsibilities as well, with like boards of medicine or certifications that a provider may need to have in order to identify as such.
Okay. Thank you, Christina. And Melissa.
Yeah, obviously, I think this section, or the cultural piece is culturally and linguistically responsive care piece has been something that we've all been kind of like trying to work through and struggling with a bit. And I think that it's still a bit of a process. Just to offer something from the provider end of things is that we are also bound by our licensing standards and our ethics. And so I would not ethically be able to claim competency or specialty in an area that I did not have some kind of specialized training, or that I did not have adequate experience in. And so it's really, the providers, that the self-report piece it does put it on the providers to only declare competency in areas where they are truly competent, because it's absolutely unethical for us to declare competency otherwise. It's something that we can absolutely get in trouble for. And, different provider types probably have different ways that they do that. Like I'm a behavioral health provider. And so on the medical provider end, maybe they have to have like a, something. Yeah, I don't even know. I have no idea what medical providers have to have in order to declare a specialty. But, I think that's one of the challenges here, is that there's variability between provider types in what they need. But I can say that on the provider end of things, that, it's absolutely unethical, and typically licensing boards align their standards with ethical standards to declare that you have specialized experience or a specialty in an area that you do not have that experience and that you do not have that training in. So I appreciate what the insurers are saying, and I am definitely want to hear their perspectives. And I don't think that an insurer is responsible for something that a provider reports themselves. But I do, it just seems like this is an ongoing discussion, and I'm glad that DCBS is going to be, using the reporting requirements to try to understand this. But all of our goals is really to give the public more information about the providers that they're seeking, so that they can get their needs met, so that, if they go and work with a provider, they're not wasting their time and trying to work with somebody who that isn't equipped to meet their needs.
Thanks, Melissa. I appreciate that. Any other thoughts? Antoinette.
So quick question here, just kind of going through, if you can go up a bit, Karen, to little B, let me see. Okay, could you scroll down a little bit? Sorry, I thought I saw something where we may be able to resolve this. Okay, go down, keep going down, please. Okay, I'll just follow up in writing on this. I just don't see it. I thought I saw something. So, okay, thank you.
Thanks, Antoinette. Yeah, follow up in writing. All right, moving on. This is just language that we just talked about, that was removed. It's just from being rearranged. All right, and then this, you'll notice, is a new rule set. This is because when drafting the previous, when drafting the rule set, I missed a relevant section of SB 822. So this rule implements section 4B of SB 822, which requires the division to adopt standards by rule to evaluate the composition of a carrier's behavioral health provider network under subsection 3. Specifically, the statute directs the division to ensure that networks include an adequate number and geographic distribution of licensed behavioral health providers who are accepting new patients, and that these networks reflect the needs of the carrier's enrollees. This includes providers who can serve children and adults, individuals with limited English proficiency, those with diverse cultural or ethnic backgrounds, individuals with chronic or complex behavioral health conditions, and any additional populations specified by rule. I did try to originally put this section into the reporting rule, but it's just too detailed and too long of a section to add to the reporting rule, so it really did necessitate its own rule set. So the new rule addresses the requirement of SB 822 by outlining what carriers must report to demonstrate compliance. It requires carriers to identify the number and distribution of specific licensed provider types, such as licensed professional counselors, marriage and family therapists, clinical social workers, psychologists, and psychiatrists available in each county, and whether these providers are accepting. It also includes reporting on provider characteristics relevant to cultural competence and specific population and population-specific needs. And this is not currently in the quantitative data reporting template because obviously it wasn't drafted in the previous rule set. But when we do put together our work group and kind of redefine the quantitative data reporting template, we will need to add these elements to the quantitative data reporting template. So thoughts about this section?
Quick question. So for little b here, this is if it's self-reported, right, by the provider. I think what we probably would request is that if it's self-reported by the provider,
I'm sorry,
soon meeting visa.
if what's self-reported, Antoinette?
Talking about a little bit, for each provider listed in A, the report must identify whether the provider is accepting new patients, all of that. Is it if it's self-reported by the provider or no?
No, the statute does not say self-report, and the statute itself requires each of these individual segments, and it is outlined under SB 822 section 1 4B. It says, let me pull it up, hold on. The department shall adopt by rule standards for evaluating under subsection 3 of this section the adequacy of a carrier's network of providers in meeting the requirements of this section and in wait. It's not it. 4B, standards adopted by the department by rule to evaluate a carrier's network of mental and behavioral health providers under subsection 3 of this rule must ensure the network includes adequate number and geographic distribution, and it lists those specific provider types, and then it says, including but not limited to providers who can address the needs of children and adults, individuals with limited English proficiency who are illiterate, individuals with diverse cultural or ethnic backgrounds, individuals with chronic or complex behavioral health conditions, and other groups specified by the department by rule. So the statute itself does not say self-report. The statute says that we must ensure that behavioral health networks include providers who can address the needs of these populations.
Thank you.
Barry?
All right, Brooke. So trying to understand. So in this new report, we have to force the providers responders, but in the prior rules, it could be the behavioral health's option to report to us or self-report to us. Am I getting that right?
Yeah, and that again, that's because in drafting the rules, I neglected this section. I missed this section when drafting the rules. And you're right, that does create kind of a disconnect between the previous cultural competency section and this section. And so, I will take a look at that.
Okay, yeah. Otherwise, I don't know what the providers on the rack, but to me that would get confusing. It's like you'll let me go here, but not here if I'm a behavioral health.
Yeah.
Oh,
I agree with that.
Brooke, what are you doing to us in these rules? Gee.
Every time I look at these rules, Gary, I learn something new and get more confused and then less confused and then more confused. It's just a very complicated rule set.
Okay, no problem. Thanks.
Any other thoughts? All right, moving down.
Seth Johnstone from Basic Rights. I just noticed that the LGBTQ component might have been missed from the previous page, but maybe it's just listed below.
Are you talking about on the behavioral health?
Correct. It was in the previous page, but here it doesn't seem listed under this piece.
Yeah, that's because it wasn't listed under the category in the in that 4B. But if we do kind of modify the cultural competency section and maybe combine those, it would probably make sense to add it under here, under that other group specified by the department by rule. So yes, thank you for pointing that out, Seth. Okay, and then this is the provider directory requirements. This was another suggestion by a RAC member in the comments. And again, this very much mirrors what is in the cultural competency section and what is currently in SB 822 as it relates to the categories identified under those that cultural competency section. So it's asking for whether interpreter services are available at the practice and what types of access are supported, whether the provider self-identifies as having specialized experience or clinical focus in one or more of the following populations, and then those categories are directly related to the categories identified from SB 822. So thoughts about this? Nobody has thoughts about this? Gary?
I was just thinking how we would report on this if we have providers that have multiple providers in the same clinic and they have different focus of view. I guess we're reporting at the provider level, right? Because it says
Correct.
at the provider's practice location.
Yeah, it would be at the provider level.
So if you have 4 providers with the same location, but they can all have different responses for disabilities, say, for example.
Well, how are your provider directories? How do they break it out at the individual provider level
Yeah.
like that? So
Yeah,
then
you
you
have to,
could,
because you can search by provider name or by a location close to where you are.
yeah.
So that's
So
what I'm saying. I'm just trying to think of the data we're going to give you, if it looks confusing or not coming in by having these. And I was just thinking multiple providers at the same location, and they each respond a little differently, but the same location. 2 service, 2 can focus on people with disabilities. One, I guess. I was just thinking out loud.
yeah, I mean, well, that would make sense because even if they are at the same location, a provider
Yeah.
could have different specialties. So you could have a provider who specializes in LGBTQ, plus services, and then another provider at the same location who may specialize in, individuals with chronic or complex, mental health conditions, correct? And they would identify those in their provider directory requirements.
All right. I'm just thinking out loud. Thanks.
All right. Thanks, Gary. All right, any other thoughts about the draft rule? And those were the last changes, I believe. Seth, go ahead.
Yeah, this wasn't highlighted, but it was in the pages above under the HPSA section. We've been trying at Basic Rates Oregon to increase the workforce for gender affirming treatment, especially knowing that a lot of the wait times that were caused were due to not having a lot of providers available who were contracted with insurance, for example, who did hair removal, which is a prerequisite requirement for a lot of the gender affirming surgeries. But we've had a lot of the roadblocks. So this was supposed to help patients and our insurers with the wait times. Those providers have reached out to us saying that they still can't get contracts, that they've had lots of roadblocks in the way of getting contracted as in network. And so we just had a concern with the HPSA section that if there's just a detailed paragraph from a carrier that says we tried, but we have evidence that a lot of providers cannot get in network, is there a submission place for that? Is it just taken by the word submitted here in the HPSA section? Sort of just curious around the accountability if we're seeing that actually there are providers available that just are not getting contracted in network.
You're talking about the section that outlines the exception process in low-income zip codes and health professional shortage areas?
Correct. It wasn't highlighted, but just a curiosity I've had throughout this process.
Yeah, so those exceptions would be coming into the division and they would be reviewed by Cassie and her team. Cassie and her team, I mean, if there were any kind of questions or any outliers or any concerns about those exceptions or, the process or any of the considerations that carriers, used in their determinations for those exceptions, then, Cassie and her team would likely reach out to the insurer to kind of have a conversation with the insurer regarding, the exception and, get some more details from them around, what the need for the exception was and, what the whether there were kind of other avenues rather than an exception. And Cassie, I don't know if you have any more to add there, but it wouldn't be that when an exception was filed, that was, the carrier filed an exception and there wasn't anybody reviewing or looking at those. The division would look at those exceptions and then kind of, if there were questions or concerns, we would reach out to the insurer and kind of follow up on that process. Cassie, go ahead.
I think you did a very good job of explaining that, Brooke. But to give some more context, with a lot of the reporting that we have coming in from insurance companies, we do engage in follow-up work. So especially if we see something that could be concerning in particular, like what you're explaining about like provider contracting for various gender affirming care procedures or whatnot, it would be something that we would look into more outside of the reporting process. So this is kind of our way of getting, the way I like to think of it is this reporting gives us like a broad scope of what is actually happening with regard to network adequacy. And then after we have that reporting and have done some analysis, we work with carriers one-on-one to address the areas where we have concerns or questions to get more information or do some additional analysis kind of more in depth outside of the reporting. That would be really difficult to make generalized, if that makes sense. So
yeah, thanks so much for
there would be
Much
follow-up.
appreciated.
Yeah.
Thanks.
Melissa?
Yeah, I just wanted to kind of echo Seth's concerns and just Seth, I don't know if you saw the comment letter that OIMHP submitted, but that we also were concerned about, we kind of, I think the term came up in the last RAC meeting of like internal administrative barriers to provider admissions, and just that we did, and I appreciate everything that you said, Cassie, and it would be nice to see something in writing, just even if it is that broad term, internal administrative barriers, just because what is in writing so far is really focused on barriers from the provider end of things. Thank you.
Thank you, Melissa. I appreciate that. Any other thoughts? All right. Done with the draft rule. Let's move on to the next section of the agenda. So we have about 4 minutes left in the meeting, I believe. The next section of the agenda is the review of statement and need of fiscal impact. I think since this is not going to be the last RAC meeting, I'm going to delay the review of statement and need of fiscal impact until the next RAC meeting. But for the RAC members, just please review the draft statement in need of fiscal impact that was provided to you in the materials, and just think about some of the questions some of the sections that are in that fiscal impact. We're kind of looking for feedback on the impact of the rules, especially how the rules might affect businesses in Oregon, especially small businesses, as well as any potential impacts on insurers, as well as other stakeholders. I'd also really appreciate any input you have on how you think the rule might affect equity in the state, particularly across different lines of identity. So I'd probably have that conversation at the next RAC meeting in January. All right, so now I'd like to give some time for public comments. So any members of the public who are not members of the RAC that would like to provide public comment, please let me know. All right, hearing none. So next steps. So like we said before, there will be a work group that we will be starting to look at the quantitative data reporting template. It will kind of work in tandem with the Rule Advisory Committee, which will be, continuing to work on the permanent rulemaking. Both of those will start in January. The RAC will start back up in January, and then the work group will start in January. I'll send an email out, soliciting some members for the work group. For those who are on the RAC, if you do know any providers who you think would be, potentially good members for this work group, please let me know. I would love, to get in contact with any providers who, may potentially be good members of the work group and would be interested in, participating in this work group. We will have the next RAC meeting at some point in January, and Karen and I will get a meeting date out to you all at some point in the future. And then I think we will discuss internally whether or not we will file a temporary rule or a permanent rule in this case. And I'll likely send that email or that information out to you all in an email as well, whether or not we decide to go the temporary rule route or the permanent rulemaking route in this case. Any questions or anything I missed? Seth.
Is there a comment period after this meeting in specifics, or is that no longer open?
Oh, yep. That's something I missed. Thank you, Seth. So yeah, it's usually 2 weeks from today. So that would be November 26th. So any comments on the rule by November 26th? Anything else? All right. Thank you all. Have a lovely rest of your day.
Thank you.
Thanks, Brooke.